Hi everyone. So today is our last class. Tuesday, but this is technically for Wednesday's course, but I wanted to get it to you as soon as I could, so you have time to finish up homework for the rest of the week. If you're having any trouble finishing assignments or if you have any assignments that are missing from the quarter, please email me and we can figure out a way to get those done and turned in on time. Well, not on time, but we'll get them turned in before the end of the quarter so that you don't miss out on anything for your grade. I'm looking at when grades are due, and so that will be when I email this, I'll let you know the last day to possibly turn in any assignments. I'm looking at grades. Everything is looking good for most people. So just let me know if you have any questions about where you're at or if you have anything missing, we can get that straightened out. So for this last class, we are covering ankle, lower leg, and foot conditions. We did a little bit of lower leg because some things cross the knee joint, but now we're going to focus more on foot and ankle. Again, slides are uploaded with this, and then you have one homework for this set of slides as well. So this will be your last assignment that is assigned for the quarter, and then your final assignment is due on Friday. So let's jump in. We're looking at slide 2. Bones of the lower leg, ankle, and foot. So we did go over the lower leg a little bit, but I wanted you guys to have a visual for what we're looking at. We have tibia and fibula, which are two lower leg bones. The tarsals are the first row of smaller bones in the foot. They are listed there for you: the calcaneus, the talus, navicular, cuboid, lateral cuneiform, and the medial cuneiform. Next we have metatarsals, and then we also have phalanges for our toe bones. So on slide 3, we are looking at regions of the foot. So the three major regions of the foot are the forefoot, the midfoot, and the hindfoot. The forefoot is composed of 5 metatarsals and 14 phalanges, along with numerous joints. In conjunction with the midfoot region, the forefoot forms interdependent longitudinal and transverse arches to support and distribute body weight throughout the foot. So there I've listed the metatarsophalangeal and interphalangeal joints, and then the tarsometatarsal and intermetatarsal joints. So those are the joints that make up the forefoot that we're looking at. For midfoot, this is the region that encompasses the navicular, the cuboid, and 3 cuneiform bones, as well as their articulations. The navicular, like its counterpart in the wrist, which is the scaphoid, helps to bridge movement between the hindfoot and the forefoot. Within the midfoot is the transverse tarsal joint. Next we have the hindfoot, and the hindfoot includes the calcaneus and the talus. Rising off the anteromedial surface of the calcaneus is the sustentaculum tali, which largely supports the talus. Located on the inferior surface of that is a groove through which the flexor hallucis longus tendon passes. The talus is saddle-shaped and serves as the critical link between the foot and the ankle. It has several functional articulations, the two most important of which are the talocrural joint and the subtalar joint. Both serve a unique role in the integrated function of the lower leg, the ankle, and the foot, and how they all come together there. In the foot, we also have plantar arches. So the bones and supporting ligamentous structures in the tarsal and metatarsal regions of the foot form interdependent longitudinal and transverse arches. The longitudinal arch runs from the inferior calcaneus to the metatarsal heads. And then the transverse arch runs across the anterior tarsals and the metatarsals. In here we also have the plantar fascia. The plantar fascia, or plantar aponeurosis, is a specialized, thick, interconnected band of fascia that covers the plantar surfaces of the foot, and it provides support to the longitudinal arch. We're going to talk later on about injuries to plantar fascia, so that is one structure that is going to be important here. I think that's the only arch type injury that we're going to look at today. On slide 4, we're looking at ligaments of the ankle, their proximal attachments and their distal attachments. There's a table on that slide for you, so you can go through and look at what we're looking at there. Each injury involves different ligaments, and then how their attachments are affected. And so there I just created a table for you to look at. So when we're looking at injuries, you could go back when you're doing your homework and see which ligament may be involved with the attachment sites for your injury. On slide 5, we're talking about kinematics of the lower leg. So the first one is the gait cycle. So this is really important here. It involves the lower leg, the ankle, and the foot. The gait cycle requires a set of coordinated sequential joint actions of the lower extremity. And so on the slide, I included a picture for you of the different phases of gait and what is happening there, and then what those phases are called, if you have double support or single support, and then what each joint is doing during each phase of gait analysis. Then we have toe flexion and extension. Several muscles contribute to flexion of the 2nd through 5th toes. These include the flexor digitorum longus, flexor digitorum brevis, quadratus plantae, lumbricals, and interossi. The flexor hallucis longus and brevis produce flexion to the hallux. Next, we have dorsiflexion and plantar flexion. Motion at the ankle occurs primarily in the sagittal plane, with ankle flexion and extension being termed dorsiflexion and plantar flexion. The medial and lateral malleoli serve as pulleys to channel the tendons of the leg muscles, either posterior or anterior to the axis of rotation. Next, we have inversion and eversion. Rotations of the foot in the medial and lateral directions are termed inversion and eversion, respectively. These motions occur primarily at the subtalar joint, with secondary contributions from gliding movements at the intertarsal and tarsometatarsal joints. Last one is pronation and supination. The lower extremity moves through a cyclical sequence of movements during gait. During this, the action of the subtalar joint during weight bearing has the most significant implications for lower extremity injury potential. Although a normal amount of pronation is useful in reducing the peak forces sustained during impact, excessive or prolonged pronation can lead to several chronic or overuse injuries, which could include stress fractures of the 2nd metatarsal, and irritation of the sesamoid bones, or plantar fasciitis. So on the slide as well is directional pictures for all of those motions and the kinematics of the lower leg, ankle, and foot. On slide 6, we start looking at our first set of conditions and injuries within the foot. We are looking at toe and foot conditions. So many individuals are at risk for toe and foot problems because of a leg length discrepancy, postural deviation, muscle dysfunction, or malalignment syndrome. In particular, when compared to a man's foot, a woman's foot has a narrower hind foot, a relatively increased forefoot to hind foot width, and increased pronation. So between males and females, there can be differences here for the incidence of injury. Toe deformities. Most toe deformities are minor, and they can be treated conservatively. A few deformities require surgical intervention to correct, like the picture that we see on the slide there. On the top right is, that one is hallus valgus, so those toes are severely deformed here, and that is not something that the person is just doing with their toes. That is how their toes are naturally occurring. So This is due from prolonged pressure against the medial aspect of the first MTP joint. It can lead to thickening of the medial capsule and the bursa, so this results in a bunion, which in this case resulted in a severe valgus deformity of the great toe. This condition may be caused by heredity, metatarsus primus varus, pes plantis, rheumatoid arthritis, and neurologic disorders. The most common cause, though, is wearing poorly fitted shoes with a narrow toe box. So signs and symptoms here, many individuals with the deformity are asymptomatic. The picture on the slide is obviously not asymptomatic. They will have MTP joint pain, difficulty wearing shoes. The condition may also cause the second metatarsal to bear more weight, leading to a callus under the second metatarsal head. Treatment varies depending on the degree of deformity and the severity of a person's symptoms. Wide and soft shoes with a broad toe box and sufficient insole padding are they're critical for comfort. So depending on the person, the shoe will change, the insole will change, and how they're treated will change. If conservative measures fail, then surgery may be needed to correct the deformity. But that does not always mean improving of activity performance. And then also rehabilitation for those kinds of surgeries can last 4 to 6 months. The picture going across the bottom of the slide with A, B, and C, that is a picture of hammer toe, claw toe, and mallet toe. These are lesser toe deformities that may be congenital, but more often they develop from improperly fitted shoes, neuromuscular disease, arthritis, or trauma. So the first one, which is hammer toe, is extended at the MTP joint, flexed at the pip joint, and hyperextended at the dip joint. So you can see in the picture where those are happening. Claw toe involves hyperextension of the MTP joint and flexion at the dip and pip joints. And then C, which is a mallet toe, is in neutral position at the MTP and pip joints, but flexed at the dip joints. Signs and symptoms of each of these conditions, they can lead to painful callus formation on the dorsum of the interphalangeal joints. This pressure against the shoe and underneath the metatarsal head, particularly to the second toe, is caused by the retrograde pressure on the long toe. Management for these, they're difficult to treat conservatively because they are, the deformity is so big. A metatarsal pad might help to control some symptoms, but surgery can be necessary. Soft tissue surgery may involve tendon lengthening, a capsulotomy, or a ligament release to help relax that joint and the following bones. For more significant deformities, a resection of the head of the proximal phalanx often is necessary to treat the condition. The next one that we have, another common one, is turf toe. So sorry. Turf toe, or a sprain of the plantar capsular ligament of the first MTP joint, results from forced hyperextension or hyperflexion of the great toe. Hyperextension causes the sesamoids to be drawn forward to bear weight under the first metatarsal head. And then repetitive overload can also lead to injury, particularly when associated with a valgus stress. Next, we have reverse turf toe. Because of forced hyperflexion of the MTP joint while kicking a ball strike, soccer players often irritate the dorsal capsular structures of the first MTP joint. This condition can be acute or chronic, and it demonstrates signs and symptoms similar to turf toe. except that pain is noted dorsally over the joint and passive flexion of the toe is painful. We also see bunions in the foot. Bunions are generally found on the medial aspect of the MTP joint of the great toe, but they can also occur on the lateral aspect of the fifth toe. Pronation of the foot, prolonged pronation during gait, contractures of the Achilles tendon, arthritis, and generalized ligamentous laxity between the first and second metatarsal heads can produce a thickening on the medial side of the first metatarsal head as it constantly rubs against the inside of the shoe. So that the bunion can be avoided in a lot of ways, but it can also be treated conservatively as well. The last one on here is the retrocalcaneal bursitis. We've looked at bursitis now in almost every joint. So external pressure from a constrictive heel cup, coupled with excessive pronation or varus hindfoot, can lead to swelling, erythema, and irritation of the retrocalcaneal bursa located between the Achilles tendon and the calcaneus. So that's what you're seeing on that last picture, is the retrocalcaneal bursa. So it's often inflamed when it is pinched between the Achilles tendon and the calcaneus during plantar flexion. Signs and symptoms for this bursitis and the management of it are the same as we've seen in all of the others before it. Ice, compression, it might appear red or irritated, it will be swollen. You can add a heel cup in the shoe to try and alleviate pain, but that also might make the shoe tighter, so that we don't want to compress it too much. On slide 7, we're looking at contusions of the foot, the lower leg, and sometimes in the ankle. Contusions of the foot and leg result from direct trauma, like all the other contusions that we've looked at thus far. Things could be like dropping a weight on your foot, or being stepped on, getting kicked, or being hit by a speeding ball. Many of these injuries are minor and treated easily with standard acute care, like we've talked about in the past. A few injuries, however, can result in complications, such as excessive hemorrhage, periosteal irritation, nerve damage, or damage to tendon sheaths, leading to tenosynovitis. So we're going to look mostly at acute compartment syndrome for the lower leg. Acute compartment syndrome occurs when a rapid increase in tissue pressure within a non-yielding anatomical space leads to increased local venous pressure and obstructs the neurovascular network. In the lower leg, it tends to be caused by a direct blow to the anterolateral aspect of the tibia, or by a tibial fracture. The anterior compartment is particularly at risk because it is bounded by the tibia medially, the interosseous membrane posteriorly, the fibula laterally, and a tough fascial sheath anteriorly. Although an acute compartment syndrome occurs less frequently than the more common chronic compartment syndrome, the acute syndrome is considered to be a medical and surgical emergency because of the comprised neurovascular functions. Signs and symptoms include a recent history of trauma, excessive exercise, vascular injury, or prolonged externally applied pressure. The increasing severe pain and swelling appear to be out of proportion to the clinical situation. A firm mass, tight skin, because it's stretched to its limits, it might appear kind of shiny. Loss of sensation on the dorsal aspect between the great toe and second toes, and then diminished pulse at the on the dorsal of the foot would be decreased. A normal pulse, however, does not rule out this syndrome. Acute compartment syndrome can produce functional abnormalities within 30 minutes. of onset of the hemorrhage. Immediate action is necessary because irreversible damage can occur within 12 to 24 hours. Immediate care involves ice and complete rest. Compression is not recommended because the compartment is already unduly compressed, and additional external compression only hastens the deterioration. In addition, the limb must not be elevated because this decreases arterial pressure and further compromises capillary filling. Referral to a physician for immediate care is absolutely necessary. If numbness in the foot is present, intercompartmental pressure is measured using either a it's measured using tools that we just don't have in the athletic training room. And then the management of this is a fasciotomy, and so you would have to, I included the picture of this on the slide. You have to open those tissues to release all of the pressure and the fluid that's building up. So that's not something that we are equipped to do in the athletic training room. So that is an immediate EMS, either EMS activation or they need to go get care at the emergency room. All right, on slide 8, we start talking about ankle sprains. This is the most common injury that happens in recreational and competitive sports. Like the other sprains that we have seen in all of the other body parts, they are classified as grade 1, grade 2, or grade 3. In the ankle, these are caused by severe medial and lateral rotating motions, excessive supination of the foot, which would be an inversion sprain, and then excessive pronation of the foot, which would be an eversion sprain. So we're going to look at those two individually and talk about different mechanisms and then the structures that are being affected there. So slide 9, we start looking at inversion ankle sprains. Acute inversion often occurs while changing directions rapidly. This injury typically involves the foot in an unloaded position and the ankle with a plantar flexion and inversion force. In plantar flexion, the ATFL is taut and the CFL is relatively loose, whereas in dorsiflexion, the opposite is true. So the medial and lateral malleoli project downward over the talus to form a mortise tendon joint. The lateral malleolus projects farther downward than the medial, which limits lateral talar shifts. As stress is initially applied to the ankle during the plantar flexion and inversion, the ATFL first stretches. If the strain continues, the ankle loses ligamentous stability in its neutral position, and that's where we get into grade 2 and then grade 3. So the picture that we're seeing on this slide is an inversion ankle sprain. So during inversion, the medial malleolus acts as a fulcrum to further invert the talus, leading to stretching or tearing of the calcaneofibular ligament, which is what we're seeing in the picture. Signs and symptoms, we're looking at, grade 1, the calcaneofibular tendon would be stretched. In grade 2, the calcaneofibular tendon would be torn, ligament, these are ligaments. An anterior talofibular ligament will be stretched. In grade 3, you will have a rupture of the calcaneofibular and anterior tibiofibular ligaments, and then a stretch of the posterior talofibular. So signs and symptoms do look different with grade 1, grade 2, and grade 3. Grade 1, they will have some pain and a little bit of swelling. They might have some point tenderness, but there will be no laxity with any of the stress tests that you do. Grade 2, they'll have a tearing or a popping sensation on the lateral aspect. There will also be pain and swelling. They will be tender to palpation, and then you might have a positive anterior drawer at this point. We'll go over that test when we're looking at special tests. And then grade 3, they will have a tearing or popping sensation on the lateral aspect. They won't necessarily have as much swelling, but you will have a positive anterior drawer test and a talar tilt test that will be positive. An eversion ankle sprain, we are now looking at the other side of things. So this involves injury to the medial deltoid-shaped talocrural ligaments, which is the deltoid ligament. Although an isolated injury to the deltoid ligament may result from forced dorsiflexion and eversion, such as landing from a long jump. On the slide, I also put tumbling, because I've seen this with gymnastics. If they're tumbling on the floor and they are tumbling from really high up, they come straight down, landing on both feet, and if their footing is not under them and they kind of invert, they can sprain their ankle that way. Evert for an eversion sprain. So tumbling from, it's called a double back. The force from that tumble is equivalent to jumping out of a 2-story window. So they're coming down. Any kind of imbalance in how they land can cause this ankle sprain as well. These account for less than 10% of all injuries. Most injuries to the deltoid ligament are associated with a fibula fracture, a syndesmotic injury, or a severe lateral ankle sprain. Individuals with promenated or hypermobile feet tend to be at a greater risk for eversion injuries. Signs and symptoms here, initial pain, immediate swelling. They might be unable to bear weight. They could have a possible popping sensation. Then ecchymosis is going to appear over the next 24 to 48 hours. It can't really, again, it changes with grade 1, grade 2, and grade 3. Management would be acute standard of care, rest, ice, compression, elevation. If you do get a lot of that ecchymosis, you can use KT tape for drainage. And then with these, you would refer to a physician if you don't see progress within a week or two, because you want to get an MRI, make sure that deltoid ligament is not torn all the way, or to rule out a fibular fracture. These can, if the deltoid ligament is torn, these can also require surgery. On slide 10, we're looking at a syndesmosis sprain. Injury to the distal tibial fibular syndesmosis often goes undetected, resulting in a longer recovery time and greater disability than with more frequent lateral ankle sprains. So, the incidence of injury is reported as between 1 and 11% of all ankle injuries. The mechanism of injury differs from that of an inversion sprain. Often the foot is dorsiflexed and externally rotated. External rotation injures the structures of the syndesmosis by widening the ankle mortise. Signs and symptoms here would be point tenderness, pain and swelling, and then difficulty bearing weight. There's 4 specific tests to diagnose a high ankle sprain, and so that will differentiate it from a regular lateral ankle sprain. At first, you would treat it the same as a lateral ankle sprain. However, if there's no improvement, again, you would refer to the physician to get additional imaging, see if any other structures have been damaged. On slide 12, we start looking at strains and tendinitis. Muscle strains seldom occur in the lower extremity with the exception of the calf, so the gastrocnemius and soleus complex. Instead, here injury occurs to the musculotendinous junction, so where the tendon meets and turns into muscle, which I believe we'll talk later about when we go over the calf strain by itself. There's a picture on there for you. Most common sites for tendon injuries include the Achilles tendon, just proximal to its insertion into the calcaneus. The tibialis posterior, just behind the medial malleolus. The tibialis anterior on the dorsum of the foot, just under the extensor retinaculum. And then the peroneal tendons, just behind the lateral malleolus and at the distal attachment on the base of the 5th metatarsal. Signs and symptoms would be a history of stiffness, following a period of inactivity. So if they stay inactive and they're still having pain and stiffness in that area, that would be a big indicator here. They could have localized tenderness over the tendon, possible swelling or thickness in the tendon, pain with passive stretching, and pain with active and resisted range of motion. Management would be conservative treatment. You can use heat therapy, which is very common, either biking or using a hot pack before activity. I really like to use ultrasound with phonophoresis, like we've talked about in the past, using a gel of medication, and then the ultrasound to get that medication down into the tendon. You can also limit activity if needed to give the body a break. You can use stretching and rehabilitation exercises. And then Graston is also useful here if there is that thickening of the tendon. You can use Graston to scrape down and loosen up that thickening that's happening there, preventing scar tissue from building up. On slide 13, we're looking at peroneal tendinopathies. Peroneal injuries are less common in the lower leg than injuries to the Achilles. Mechanisms of injury for peroneal tendon may include forceful passive dorsiflexion, which occurs when a skier catches the tip of their ski and falls forward. Exploding off of a slightly pronated foot, so like when a football player is in a three-point stance and makes a forward surge, or being kicked from behind in or around your lateral malleolus. Tendinitis of peroneus longus causes pain as the tendon passes beneath the cuboid toward its insertion on the plantar axis of the metatarsals. Another problem that may exist involves the retinaculum that holds the tendon in place on the posterior aspect of the lateral malleolus. So it kind of acts as like a cover, and sometimes that will tear, and then the tendon can pop through in subluts, and that gets very uncomfortable. This condition can be overlooked or confused with an ankle sprain because it gives a feeling of instability and pain over the lateral malleolus, but it is different from an ankle sprain. So the top picture on the slide shows the retinaculum, where it is holding it in place, those white bands that are going from the calcaneus across the top of the foot, and then the second one from the calcaneus to the malleolus there. So those can be torn, and then it won't hold this tendon in place, and then it will pop up and over the lateral malleolus, which is extremely uncomfortable. Signs and symptoms here would be a cracking sensation followed by intense pain and the inability to walk, swelling and tenderness, extreme discomfort or apprehension when trying to do inversion of the ankle. Management would be ice compression, elevation, and rest, rehabilitation if possible, but if it is a retinaculum injury, then we would have to do surgery to repair that. On slide 14, we're looking at a strain of the gastrocnemius muscle. Strains to the medial head of the gastrocnemius often are seen in tennis players and older tennis players, older than 40. Common mechanisms are forced dorsiflexion while the knee is extended, or forced knee extension while the foot is dorsiflexed. And then this is that picture that I was telling you about earlier, where you can see that musculotendinous junction and where injury is occurring right at that junction. This can also be related to muscle cramping. If an athlete experiences muscle cramps, they can strain their muscle as well because they're cramping so much, and then that muscle could tear as well. So here we are also looking at grades 1, 2, and 3, like we have with every other strain that we've seen. So signs and symptoms: a sudden painful tearing sensation, immediate pain, swelling, loss of function, and stiffness. So loss of function would be depending on which grade it is, 1, 2, or 3, how torn the muscle junction might be. And then you could experience ecchymosis down the leg and into the foot. So management, you want to control that inflammation using ice and compression, elevation as well, and then we could also use KT tape like we've seen in other strains. You could use e-stim to modulate pain in those first couple hours and days of the inflammation process. And then you would use rehabilitation to build strength and to build that muscle back up again. Slide 15, we start looking at Achilles tendon disorders. Achilles tendon disorders occur most often in athletes, and of those, most often in individuals who are involved in running sports. Generalization is Achilles tendonitis or posterior heel pain, but more than likely it is an overuse injury. Let's see. We're going to look specifically at an Achilles tendon rupture. So acute rupture of the Achilles tendon is the most severe acute muscular problem in the lower leg. It is more commonly seen in individuals from 30 to 50 years old. The usual mechanism is a push-off of the forefoot while the knee is extending, which is a common move in many propulsive activities. Tendinous ruptures usually occur 1 to 2 inches proximal to the distal attachment of the tendon on the calcaneus. Signs and symptoms here: the individual hears and feels a characteristic pop in the posterior ankle, and a lot of times they'll report a feeling of being shot or kicked in the heel. Clinical signs and symptoms include a visible defect in the tendon. On the picture that I included in the slide, you can see the defect there and how different it looks from normal to abnormal. They will have the inability to stand on their tiptoes or even balance on the affected leg. They will have swelling and bruising around the malleoli, excessive passive dorsiflexion, and a positive Thompson's test. So we'll talk about the Thompson test later on in assessment. Because the peroneal longus, peroneal brevis, and muscles in the deep posterior compartment are still intact, the individual may limp or walk with the foot and leg externally rotated, because this does not require push-off with the superficial calf muscles. So management here would be to immobilize them. A compression wrap should be applied from the toe to the knee. The leg and foot should be immobilized in either a posterior splint, or you could put them in a boot. The individual should be referred immediately to a physician. You don't necessarily have to go to the emergency room, but getting them seen within 24 to 48 hours is very important. For older patients, non-operative treatment does offer excellent functional results, but if you're dealing with athletes and younger people, surgical intervention is needed, and then rehabilitation is 6 to 9 months for this injury. On slide 16, we look at plantar fasciitis. This is an overuse condition. Plantar fasciitis is the most common hindfoot problem in runners, affecting approximately 10% of participants. Extrinsic factors that increase the incidence of the condition include training errors, improper footwork, and participating on unyielding surfaces. Intrinsic factors include the formation of your foot, decreased plantar flexion strength, reduced flexibility of the plantar flexor muscles, excessive or prolonged pronation, and then torsional malalignment within the foot. These factors can overload the plantar fascia's origin on the anteromedial aspect of the calcaneus during weight-bearing activities. In chronic conditions, entrapment of the first branch of the lateral plantar nerve can contribute to pain syndrome. Entrapment of the posterior tibial or medial calcaneal nerve can mimic or complicate this condition as well. Signs and symptoms would be pain on the plantar that reoccurs after rest, so pain throughout the bottom of the foot, that doesn't necessarily go away when you stop doing activities. These injuries are most painful in the morning after the person has slept, the foot has been relaxed all night, so that muscle or that plantar fascia has been taut all night, and so in a relaxed position, and then when you stand up and stretch it out and take that first step, it's very painful. And then they'll also have pain that increases with weight bearing. Management here, ice and rest are the most beneficial. There are splints that athletes can sleep in that will help keep that plantar fascia stretched more so it doesn't get relaxed. And then when they wake up, it's already stretched. Stretching of the plantar fascia and toes, rolling out on a golf ball or rolling out on a frozen water bottle are very useful as well. Athletes might want to consider insoles or new shoes with different support. However, you can tape the foot, and there are specific braces that they could wear as well. The last injury that we're going to look at is medial tibial stress syndrome, or what we also know as shin splints. These are seen most commonly in runners and jumpers. Sorry. It also can be associated with stress fractures. So when you have an athlete that comes to you with this type of pain, you want to rule out any factors that could be associated with a stress fracture as well. Originally thought to be related to stress along the posterior tibialis muscle and tendon, causing myositis, fasciitis, and periosteitis. It is now believed to be related to periosteitis of the soleus insertion along the posterior medial tibial border. The soleus makes up the medial third of the heel cord as it inserts into the calcaneus. Excessive or prolonged pronation of the foot causes an eccentric contraction of the soleus, resulting in pain. So signs and symptoms for this stress syndrome would be dull and achy, constantly dull and achy, although sometimes it can be sharp and penetrating during activity. Athletes can experience tightness in the calf as well, possibly coming from that soleus. And then they can also sometimes have pain that radiates if their condition worsens. Management would be 5 to 7 days of rest, which are essential to relieve acute symptoms. Other modalities have not been shown to be as effective as just rest, but you can use cryotherapy, NSAIDs. You can do injections here. You could also do heel pads or be on crutches or try activity modification. You want to do pain-free stretching of both the anterior and posterior musculature to help improve joint mobility. And then strengthening of the anterior tibialis muscle is going to be important here. If the participant does continue in activity, an ice cup after activity will also help modulate the pain. On slide 18, here we're starting our assessment, going through palpation of the foot, the lower leg, and the ankle. We have 3 sections to go through here. You can do anterior and medial palpation, anterior and lateral palpation, and then posterior palpation. Again, going through this list, these structures should be familiar to you. And then at this point, you can practice on yourself, or maybe you do have someone that you can practice on at home. Just trying to feel what each of these structures looks and feels like. Is it really important for you? On slide 19, we look at the active movements of the ankle, mostly the ankle and toe here because we'd already talked about the knee and the lower leg. So dorsiflexion of the ankle is you can get up to 20 degrees. Plantar flexion of the ankle would be between 30 and 50 degrees. Pronation of the ankle is 15 to 30 degrees. Supination of the ankle is 45 to 60 degrees. And then you have toe extension, toe flexion, toe abduction, and toe adduction. Those ones we don't necessarily measure with a goniometer because they're just way too small. On the picture there, though, it does show you how to measure with the goniometer, which I think you've learned in other classes, or you will if you're a junior, how to measure dorsiflexion, plantar flexion, pronation, and supination of the ankle. On slide 20, we are looking at stress tests in the ankle. So let me find my spot. All right, so stress tests, from information gathered throughout history and then observation and inspection and palpation, you have now decided, you've now determined which tests will assess the condition most effectively. So only those tests that we've talked about, or we have talked about, to only perform the tests that you deem absolutely necessary at this point. So first we have the anterior drawer test. We have seen these words already before in the knee, but in the ankle it is a little bit different. So this test assesses collateral ligament integrity of the ankle, just like it did in the knee. So while the individual is supine, the foot is extended beyond the table. There is a picture of this one on for you. It's going to be figure A. So back to that. The foot is extended beyond the table, and then the examiner will stabilize the tibia and fibula in one hand, and then cup the individual's heel with their other hand, testing both of the anterior talofibular ligament and the deltoid ligaments. This involves applying a straight anterior movement with slight dorsiflexion. A positive test result on the lateral side of the talus shifting forward, so you'll feel laxity in the ankle there. If you have an absent end feel, that would be a positive sign. If you have a firm end feel, that would be a negative sign. In picture B on that slide is the talar tilt. So the calcaneofibular and deltoid ligaments are tested in the same position described for the anterior drawer test. Maintaining the calcaneus in a normal anatomical position, which is 90 degrees of flexion. The examiner will slowly rock the talus between inversion and eversion. Inversion tests the CFL and eversion tests the deltoid ligament. Again, feeling for that end feel of those ligaments there. The last one in this picture is Kleiger's test, or external rotation test. The examiner passively dorsiflexes the ankle and rotates the foot laterally. Pain in the area of the lateral malleolus indicates injury to the syndesmosis, or the high ankle sprain that we talked about. On slide 21, we're talking about special tests. So we have a variety of special tests that can be used for detecting injury or related pathology involving this lower leg, foot, and ankle. So the first one is a Thompson test. We talked about this for the Achilles tendon. So this is in figure A for you guys, the first picture on the slide. So while the individual is prone on the table, the examiner squeezes the calf muscle. A normal response is a slight plantar flexion. A positive test indicates a rupture of the gastrocnemius soleus complex or an Achilles tendon rupture. And this is indicated by the absence of plantar flexion. So if you squeeze the calf and nothing happens in the foot, that would be a positive sign. Next we have Homan's sign, which is the next picture on the slide. This is to test for a DVT, or deep vein thrombosis. The individual must be supine on the table. The examiner dorsiflexes the foot of the involved leg with the knee in full extension. Pain in the calf indicates a positive Homan's sign. Tenderness may also be elicited with palpation of the calf. In addition, swelling in the leg may be accompanied by an absence of the pedal pulse on that leg. The next picture is Tinel's sign, which we saw already in the elbow, so now we're seeing it down in the ankle. This is to determine the presence of tarsal tunnel syndrome. The examiner should tap the posterior tibial nerve as it courses posterior to the medial malleolus. The test is positive if numbness, tingling, and paresthesia occur. And the last one is Morton's test. The patient is in a supine position with the foot extended over the end of the table. The examiner applies a transverse compression of the heads of the metatarsals. If sharp pain occurs, the test is positive, indicating a Morton's neuroma. And then lastly, we have our neurologic tests, which we've had in every joint as well. Testing myotomes using isometric muscle testing, and this should be performed using the following motions to test different segments. So knee extension, we're testing L3. Ankle dorsiflexion with L4. Toe extension, we'll test L5. Ankle plantar flexion, foot eversion, or hip extension, we'll test S1. In the foot and ankle, we have the same reflexes as we did in the knee. So the patellar tendon and the Achilles tendon. Those are performed the exact same way that we talked about in the knee. And then last, we have cutaneous patterns. The segmental nerve dermatome patterns for the pelvis, hip, and thigh are in the picture on the slide for you. And then an A is the anterior view, and then B is the posterior view. So that is all we have to cover for lower leg, foot, and ankle. And this is our last lecture of the class. So if you have any questions or have any worries about where you're at in the class or homework that you have to finish or anything like that, please email me this week and let me know. If you are having difficulty finishing any of the assignments, also please reach out and we can work out a plan to help you get those taken care of. I think that's all I have for you. The rest of the assignments are on Canvas. If you don't know or if you can't find the instructions for the final project, those are due on Friday. But again, reach out if you need any help with that.